Let's start with it. Hey,
Hi. Well, first, before we start, this is episode 20. This
I
is
believe
a
so. So I
big
couldn't remember,
deal.
like, if it's, I think we had a non-episode episode, so that may have
Yeah, well,
been
I had a conversation with Ben Gallen. That was an in-between episode, but this is the real episode. So,
rocking and rolling, and now we have
congrats,
thousands of
Alex.
people.
I don't know if we ever told our expanding audience that we just met on LinkedIn and posed the question, "You want to start a podcast?" and agreed to it. And
I
we
know.
finally
So
met in person for the first time 3 weeks ago in
yeah,
Chicago.
but isn't it amazing how it, like, so you don't appreciate technology until you do this, right? We're able to communicate. We're able to hold these sessions, uh, probably what, 1,200 miles away, the full live video, live audio. And we can send documents to each other remotely, just seamlessly, right? Think about it. Like 20 years ago, this can't happen. So we can't
Uh-uh.
see each other. We maybe can have a phone call, right? We can have a conference call, but we can't share the documents. We will have to like fax the documents. You have to go to a fax machine and get it. And then 40 years ago, none of this was available. Like you dial tone, you pay $2 a minute because it's a interstate call. So
Totally.
how far we've gone, right? Like, and it makes you be optimistic about how far we have gone just in the last 10 years. Think about what the next 10 years are going to bring.
So true. It feels like we started it yesterday. So I'm just glad that our idea was a good one.
Yeah.
And we ended up liking each other and getting along because we didn't know each other at all before we started this, right?
Yeah. No, for sure. It's been great. And like, I'm getting so much positive reception that when I'm touring these conferences, like there's people listening. I think people are getting information. And I think it's such a big benefit for them to get access to your knowledge and to your ideation. But also it's a privilege for, I guess, or it's a luxury for you to be able and willing to share your knowledge, Dana.
Well,
It's,
you too, Alex. It's geez, not just me, but I am happy to see directionally more positive feelings about value-based care. Something that we should be excited about and happy about and want to be a part of. And that's really the like that starts the fire. Is this metaphor working? I don't know.
oh
It
no,
becomes a
it's
blaze.
right on. I think about what like even what we may have ignited if you're going to do into the kindling fire. Look at our friends in Alabama. Look at Jonathan and Cody, really
Oh
moving
my
things
God, yeah.
along, and they are like they're having conversations. They're speaking to different agencies, to employers, and they're putting physical therapy on the forefront of healthcare delivery. Like that is how the grassroots movements start. It starts in a state, and each state then learns, and ideally on a federal level, we gain a lot more agency, and we become much more than physician extenders. And that would be for me a mission accomplished because
Hmm.
once we have a greater role in a healthcare system, then we're good. We've done what we can and passed it on to the next generation, right?
I mean, that's half of our goal, at least for me. You know, the two of us were in the middle age bracket, and we've been around a long time and had lots of different roles. And I don't want to leave the working world down the line at some point without having feel like I've contributed back to my profession as much as I can from what I have learned outside of it, but still within healthcare. I mean, neither one of us has ever totally left healthcare. It gives us a different perspective by having
Absolutely.
that broader scope, I think, around what healthcare looks like. And
I
anyway.
think it's like that. My reason for leaving clinical care full time was that low ceiling, right? Like the low bar that you have a threshold and then you plateau. And I think that this is a good discussion. So I ran into Drew at the Texas conference, and just that discussion of creating opportunities for clinicians to actualize, creating ideas for them to go farther. And so like he's really doing a good job on the APTA level, moving the needle in the right direction. And then. I don't know if you know Lisa Fleshner. She's wonderful. So she's really right now a consultant, but she's trying to bridge the gap between academia and clinical care. So she's an academic, she's a clinician, and she's an idea thought leader. And so her concept is how do you keep clinicians, right? How do you keep clinicians from getting burnt out? But the
Mhm.
burnout is such a so that how do you give people enough of challenge so that they stay in a discipline and continue to work? So we actually had an interesting discussion yesterday about a Dunning-Kruger effect, right? And the Dunning-Kruger effect, like if you know, it's a point of cognitive dissonance where a moderate amount of knowledge leads to overconfidence in your knowledge and abilities. So as the knowledge peaks, our confidence in our abilities declines, and then it's a paradox, right? So it's an inverse proportional relationship.
Yep.
The smarter I am, the less I'm confident that I'm smart, and vice versa. I think, like, as a point that 23 years later, I know that there's so much I don't know. That's why having conversations with you is so insightful. So discussing that, like, clinicians, like, we know that most clinicians entering physical therapy profession at a gap between 3 and 5 years start to leave the profession, which is a huge loss, because as a society we invest in education, as a culture we invest in education, and the actual threshold for extraction of this investment is about 7 to 10 years into practice. That financial investment into your academia, that clinical investment into your training, that personal investment into becoming good at what you do to trade-wise, doesn't actualize for at least a decade later. But that confidence where you feel like you know your stuff, and then 2 years later you feel like you're not going anywhere. So you start looking for these non-clinical roles, non-clinical positions, and then next thing you know, you left the clinical care. You're in some kind of a sales position, and then what, right? It's good, and not to comment against sales professionals, but if you're a trained physical therapist and you're selling EMR systems, which, right, in a way, guilty, or if you are a clinician and you're selling some gizmos and gadgets, did you really need to get a PT training to sell gizmos and gadgets to be at sales? Or could you have just gotten a bachelor's degree in business administration and then get into the sales role? So I think it's a loss to our profession when we are hemorrhaging young clinicians to non-clinical roles because our pay is low, the pressure is high, and as employers, we're not doing enough to help clinicians actualize. We're not giving them that opportunity to grow because of that low ceiling. So sorry, that was my,
No,
yeah.
so true. I mean, and we talk a lot about value-based care, but why do we think therapists care about it? Because I hope this message is coming across. It's how you can make more money. I mean, why you should care is not just because it's better for patients and outcomes and all of those soft, touchy-feely good things that we should and say we do, we know we care about. It's how you make more money, getting money out of the expensive places and bringing it to the upstream care. And it is unsustainable when you can't take a profession graduating students with essentially 3/4 of med school and sometimes 200,000 in debt and expect to keep them in a profession making max what let's be realistic, 120 at the absolute max.
Yeah, that's the
It's
key, and that's when you have, yeah.
ludicrous. Think about how insane it is that we expect this. Nurse practitioners, 2 years of grad school, they come out making ballpark 150. Physician assistant, same idea. The disconnect here is so massive. It's insanity producing to me to think that we can solve anything if we don't solve how do therapists get paid more. It's a two-pronged thing. Value-based care is the only long-term solution.
And it's
But
not
we have
about
to have higher
exactly.
fee-for-service schedule too. We need more
Yeah,
codes and we need to be reimbursed more for them, but we need to move towards value-based care where we're being paid for our outcomes because we are great at outcomes
we
that are
are.
low cost, right?
But I think it's about realizing too. I think we need to realize that there's high value and low value care, even in a high value profession. So
That's right.
as clinicians, if you're a DPT, if you're an OT, right, you have to realize that your skill set is being able to identify barriers to recovery and being able to create a plan of care that is viable and actionable. You're not the one who has to execute the plan of care, not the entire thing. That is why our profession has physical therapy assistants. That is why we can rely on trained coaches.
That's right.
It's already been done, right? And coaches is a taboo term in physical therapy profession because they're non-licensed professionals. The truth of the matter is, if you have ever been in a physical therapy clinic, you know that there is at least a cohort of technicians that are running around and doing most of the exercise supervision, right? These are probably trained individuals that don't have a license that supervise your care because you have to juggle between 4 or 5 patients an hour in order to make this fee-for-service plan meet. So why don't we reorganize a little bit? And I know Drew spoke about this a little bit too, but there is a way of structured delivery of care using a team-based model inside an outpatient orthopedic setting where physical
Right.
therapist assesses, creates a plan of care. Physical therapy assistant is a skilled professional that can deliver that plan of care. And then technicians can be extenders for these redundant or non-skilled parts where you don't need a PTA to transition between different platforms when you need to do some neuromuscular re-education. It can be a coach or a technician that oversees that redundant low value part. But we have to be the ones taking ownership of it instead of saying, no,
Mhm.
I went to school for 3 years. I need to be holding my patient's hand for 55 minutes every time because that we're creating our own ceiling. Then if you're going to be supervising your patients for 55 minutes at a time, your ceiling is like 8, 10 patients a day. And then what? Right? An average net revenue per visit for an outpatient setting, depending on the state, is like, let's just throw out a number, $110 a visit. $110 a visit will not pay the bills. Unit of production, your cost of unit production is about that. So that means that your salary, your overhead, your insurance, your EMR and tech stack, all of that combined costs about $100 a visit. How do you pay for your higher salary if you want to make twice as much as you do? You don't. You can't see 20 patients a day because then you're going to be working 20 hours a day. And then what? So you work smart, and you work smart. That means that you delegate responsibility. You are a physical therapist. Delegate, create plan of care. You intervene with patients, but not in a point where your time is being allocated to your service. Time is not equivalent to quality. Time is redundancy. Quality is knowledge is expertise. And that's we spoke about this before, where there's expert economy and there's skill economy. And we need to move
Mhm.
away from being skilled professionals. We have skills, but skills are part of the expertise. Expertise is knowing when these skills are necessary.
That's right.
And that's yeah, so sorry. That's
No, that's right. I mean, the expertise is the higher bar. The skills are table stakes. That doesn't make us a full-on doctoring profession. It's the expertise.
mm-mm,
Drew talked about this on the episode we had him on. It really is about that expert economy. I tend to draw parallels between us and medicine because therapists should understand what's happening in medicine. What are primary cares and others, thinking about? Community health workers now, okay? If anybody's following this, in the physician fee schedule, there's a incident to billing code for community health workers. Like, this is not a skilled job. It is a on-the-job trained. They do not have to have any medical background. You can hire community health workers to do supportive services in a therapy clinic. You can't do the incident to billing because we don't have the physician codes to bill for it. But those are the kinds of things that we could be speaking to policymakers about at CMS, for example, so that we have access to something like the billing of, supportive team-based care codes. Community health workers are common, so are health coaches. I was at a conference a couple of weeks ago. A vendor that probably everybody's heard of, Omada Health, was there. It was a panel about GLP-1s and the fact that somebody else on the panel brought up, look, they're not medications. They are part of a treatment package, and they were FDA approved with the understanding that you're not just getting the medication, you're getting the health coaching and support around them. So, when we talk about digital first, why are digital first companies having an easier time? We are being disrupted whether we want to hear it or not, right?
yeah,
And so things like apps and coaches and community health workers and right, like in between care, supportive care, remote care, these things are all part of the regimen that patients are going to come to expect. So we have to your point, start by building a small team in your clinic.
that's right.
Right? Hire a coach, hire a CHW and work with them and build a framework so that they can do something to help. Let's say it's just continue patient engagement. It's a heck of a lot more cost effective to hire a community health worker or a health
hmm
coach to partner with your patients. Then you're ready to get into something like a 6-month bundle where you can benefit. You have a lower cost, really an extender to the team who's not clinical, who you train to be a support. You shouldn't be doing all of that yourself,
Mm-mm,
right? It's
no,
not your job. Someone
no,
needs to say this. It's not your job. Your
that's right.
job is to provide that top level expertise and make sure the team is doing what they need to do so that your organization meets its goals.
Yeah. Let's go back to the same metaphor that we used before about the restaurant. So when I was in Paris, like a year ago, right? Like there was a really quaint, nice little restaurant in Montemart, right? Like it was like 3 tables, and the chef was also the greeter, was also the waiter, was also the sommelier, which was great. And it was such an intimate, personal experience. But the chef could only go through probably 3 tables an hour. Like it was like his ceiling was kept. That's why his restaurant was very small. His costs were probably small too.
Right.
But
That's
that
fine. That works in that business model.
absolutely. But that chef, right? He was working hard, but he wasn't working smart because his meal was exquisite. The experience was good. But the chef is probably not living a very good quality of life because the prices were not exorbitant, right? So unless he wants to charge $1,000 a meal, a plate, which he probably can't because of the competition, he is not willing to delegate responsibility versus, not to use that as an analogy, but you can go to Applebee's and then there's stations, right? Like there's a sous chef, there is a main chef, there's a line chef, there's a waiter, there's a greeter, there's everyone who does these things. And you're getting this subpar, mediocre meal because like everything is done not to poison you, but not done to satisfy your hunger. There's a middle point where you don't need to be this fine chef that does everything in France or this line chef in Applebee's. You can run a good restaurant, but you have your greeter, you have your waiter, you have your sommelier. And some of these responsibilities, right, like you can transition. So if you don't have the budget, then you create a wine list. Then if you don't have a budget for a dishwasher, you wash dishes after the meals are served. But you still have to have delegation of responsibility because otherwise you're the only one trying to cater to everyone, and you either disrupt the service or you provide a subpar service.
Mm-hmm.
Same thing goes in the clinic, right? So visiting clinics, and you see some settings where clinicians have to oversee 3, 4, 5 patients an hour because of the fee-for-service model. You can't tell me that it does not disrupt quality of care. Like the service is inferior, even if the clinician is superior. So even if the clinician is perfect, smart, personable, really well trained, and the skill set is really on top of the license. You can't provide top of the license care when you are just running between patients every hour, where you're getting this like full cohort, and you're not using extenders. Versus a more of a cash clinic, right? Or like more of a concierge type of care, where you have a clinician that for a cash payment is overseeing care that lasts 55 minutes. Now that's customer service. That's not quality of care, right? Like that clinician is willing to provide customer service by holding somebody's hand in exchange for premium payment. That's not sustainable. So because again, you have a ceiling of how many patients you
Mm-hmm.
can see in one day, in 1 hour. There has to be an in-between point. There has to be a point where you as a clinician can provide evaluation. You as a clinician can intervene if there's a question, but you also have a PTA that extends your care. A PTA is a licensed professional that is probably as skilled in delivering clinical services as a PT, most likely even more skilled because that's what they do. But then you create your own station. You create a transition point. I have done my job. Now you transition to my associate. Now, once my associate is done with you, you transition to an extender. These are healthy options to sustain our profession. And you take on risk. You don't just say that I'm only going to play in these insurance models. You take on risk. You are able to stand then by your quality of care by saying that I will take responsibility if you were to not be satisfied with your clinical outcomes, or I will take a
That's right.
financial responsibility, or I'm going to oversee your post-operative care for X amount of visits because I know that that's a predictable number, that most of the patients will do well with X amount of visits, right? And I'm going to take on this risk. So we need to move to that position. We are there. Like this is not a point again that's coming in a year or two. We're here. We are struggling. So what do we do to move to the next step? Like how do we
And we
get
don't need anything we don't need to do that. Everything is in place that if you choose to as a practice, you can start this today or tomorrow. And I draw these parallels again between medicine because we need to be aware of these parallels so we can think about how they apply to us. I hate the term physician extender for us because that's not what we are. We're our own profession. We're not medical professionals that we prescribe medication. So we're not physicians or PAs or NPs. We are our own profession and we have our own extenders. PTAs are our extenders. So if we think about how does a surgeon use a physician assistant, right? Like NPs tend to work more in primary care, and they do in some states have full autonomy, similar to us. PAs do not have full autonomy. They have more autonomy in certain states. But how does a surgeon, orthopedic surgeon using a PA, The orthopedic surgeon does the parts of the surgery that are so complex and crucial that only the surgeon can do them. And everything the surgeon can pass on to the PA and the rest of the surgical team, they do because they're thinking about what is my top of scope? How do I optimize my efficiency and my value so that I can build a team to support the care that I'm providing to this patient? Now, I'm not generalizing this to say, oh, they're doing all of the right things to prep for surgery or after surgery. No, I'm saying in the case of the job to be done of an orthopedic surgeon using a team that includes physician assistants, the surgeons are doing what they should be doing and passing the rest on to the team, whatever their top of license is, because that's best for everyone. And to your point, they have the skill to do. The surgeon knows what they should be passing on to the PA, and they know their top of scope. And this is why you don't hear a lot of PAs in surgery complaining about their job. They're given a lot of agency, and those surgeons have a lot of agency. We are no different. We are a direct access, top of license professional who should be using our PTAs, our quotas, to build a team to provide the care that only we can provide and everyone else doing everything else and setting that expectation from day one with patients.
Absolutely.
Even that step, it's better now. It
Hmm.
is more efficient and more valuable now for everyone. And it prepares us for this world of team-based care or primary
Absolutely.
care, physician and APPs, right? And then you have RNs, you have behavioral health providers, you have medical assistants, you have MSWs, you have community health workers, you have a whole team. But the
Absolutely.
physicians are doing the job of the physician and they're passing everything else on, and it's better for everyone.
Yeah, I think so. There's two things that you said that are absolutely need to be repeated. And one is setting expectations. I think you, as a clinician, need to be the coach that needs to tell your patients what to expect in their
Mm,
care. And we so often neglect to do this, where we are feeding off patients' prior expectations, even if those prior expectations are not viable or not reasonable, because we are accommodating. We are trying to please instead of being professionals and coaching what to expect in the future delivery of care, or what is your plan of care going to look like. Why do you need to be present and compliant? What does your compliance mean to your recovery? What is the threshold for your recovery? What is the expectation of prognosis to your recovery? That is what professionals do. That is what expertise allows you to do. If you have someone who is medically frail with multiple comorbidities and is morbidly obese, recovering from joint arthroplasty, you can set expectations to be lower because of these comorbidities. And that's just being a professional, outlining some of the facts. Now, communicating with a patient to expect your length of care is going to be longer because of your comorbidities. Your clinical recovery may be suboptimal because of some of the physiological factors that are involved in your care. And you can expect a higher level of independent involvement if you're looking to prognostically elevate your clinical outcomes. But as clinicians, we don't do that, right? We receive patients because they're being referred to us. And then it's almost like getting manna from God, right? Like it's like somebody sprinkled this manna and like, yes, I eat again for a day. I'm so happy. Eating a day for a day doesn't sustain your hunger for a lifetime. That doesn't get you to where you need to be. As a professional, you take ownership of your patients, you start coaching them. But then if you're in a clinic with other clinicians, you become the quarterback of that change, right? Like you are the agent of change where you address it with other clinicians. And if there's rigid clinicians that say, no, I did not train for a physical therapist to do this, I am just an extender. Is that the person you want to have as part of your team? Like, especially if you're a progressive clinician, right? Then maybe that's not a clinician that needs to be a part of your team. Maybe that clinician can fulfill a different role. But we're talking about progressives, Dana. We're talking about clinicians that see that in 2025 we are at this cusp, right, where we can either grow
that's
or
right.
we continue to decline. And I would hate to see our professional decline because we are too good. We provide too much value to healthcare. We provide too much value to our patients to just watch ourselves fizzle away and watch other industries keep chipping away at our autonomy until the point where we become what we were 7 years ago, which that would be unfortunate.
Wasn't this, Alex, to your point, this was the purpose. I remember back in 2000 when it was the 2020 goal
Since
and
2020.
right? And we moved to a doctoring profession and we moved to full direct access because the APTA and the powers that be recognized that our education prepared us to be full scope, top of license doctoring professionals. But we did that first part. We established that need, but we never fully stepped into the role. And I've been blaming it all this time on, well, we have different educational levels of professions. We still have these bachelor's therapists who do feel underprepared potentially to do a lot of the work that a doctoring professional PT has been prepared to do. I've argued before, and I'll say it again, I felt my master's in PT back in 1998 was very extensive. And when I went to get my transitional doctorate, there were very few gaps. But now we're getting to the point where we almost don't have excuses. To the bachelor's therapist, you should have gotten your transitional doctorate, and you still should. If you have the ability, it'll achieve things for you didn't imagine, and there's no downside. You're just benefiting yourself. They don't make it impossible. It's very supported. Most of it's remote, etc. But we have to now all hold each other, no matter what our peers' educational background is, how far they went. We have to hold each other accountable. I distinctly remember being one of the few master's degree therapists years ago, but when we had to do med rec in home health, I had a few other therapists willing to do the OASIS because we don't do med rec. Well, CMS says you do. What do you mean you don't do it? Of course you have to be able to do med rec. That's part of our job. It is part of what we are committing to doing if we're working in home health. And if you get a referral, we talk about agency and outpatient therapy. It's kind of easy to imagine that. There's no excuse in any setting, even if it's a Medicare Part A setting. You get a referral in home health, you know it's not skilled, you do the eval or you just discharge the patient, you pick up the phone, you call the physician and you say, hey, I've had the patient in the past a week ago. There is no skilled care. Here's the problems. They need more social support, whatever it is. And you don't accept the referral because it's not appropriate. And we have the agency to say that. And we shouldn't be signing a plan of care for something that isn't skilled. There is no excuse no matter what you're setting. And it's time we get tough with each other. Say, look,
Absolutely.
it's up to all of us to do better.
I think that is right on, and I think we've used this metaphor before, but a high quality clinician based on how many patients they refuse to see, not by how many patients they can cycle through. So I think being able to cycle through 20 patients a day is a unique skill set, but being able to say this is not the right clinician diagnosis, this is not the right setting for me. Now this patient needs to be seen by other professional. Recognizing these things is what makes you top of the scope, not being able to oversee high volume. So let's. I wanted to discuss this personal experience. So I had a little bit of a healthcare crisis in my own household. My father had a series of health problems, and I think that was me getting the phenomenology of healthcare in the United States. Right. Myself, I'm generally a healthy 47-year-old male. I have no real physical demands. So I don't really tap into the healthcare system as a consumer. I tap into it as a provider, but not a consumer. Here, seeing a family member being a consumer, but not just a consumer, a high volume consumer. Because when the medical crisis happens, like you see each stage of healthcare experience, right? The emergency room, the hospitalizations, the procedures, the multiple disciplines that come and provide triage to stabilize this individual. But then you also see that the fractured system that we are participating in, and fractured in the standpoint of there is still no communication between different disciplines. There is so much redundancy and room for error because each discipline does not read the notes from another discipline. Each discipline does not take accountability for the actions. So I think I'm lucky enough that my sister-in-law is a physician who was quarterbacking the entire medical system. And if she wasn't quarterbacking, I think there was at least 10 errors a day from a healthcare professionals not communicating or not investing an effort into understanding this complex clinical experience, right? This individual who has multiple comorbidities also. So I think that was just an eye-opening how a general consumer who doesn't have a physician as your quarterback will more likely to receive suboptimal clinical service that results in potentially suboptimal clinical outcome in a US-based hospital system. Like this is a Chicago-based hospital system. So I don't know, that there was definitely a moment of awakening that it's 2025 and we still have a vastly fractured utilized or suboptimal clinical delivery system. So that was my experience for the last 2 weeks.
I'm sorry that you've had that experience. And, healthcare is not safe. Acute care is not a safe. You do not want to end up in a hospital. Hospitals save lives, absolutely. They are ripe with opportunities for errors. There's something called the High Reliability Organization Journey. If anybody's heard of that, the HRO journey, I was very fortunate to be in a health system that joined the HRO journey years and years ago, recognizing that this was going to be more and more important and that they had to reduce medical errors. In the beginning, right, everybody's encouraged to report, and this makes it look like the hospital's less safe. But in reality, it's exactly what needs to happen. Everyone has to feel culture of safety. They need to feel that they can report near misses, et cetera. They learn from it. The hospital becomes safer. All of the people that are touching a patient, all of the handoffs, all of the distractions, just the journey from the ER to discharge is ripe with risk. Never mind the transition out or to somewhere else. And the communication, there's no incentive to communicate well. Nothing more comes to the hospital in terms of reimbursement and fee for service. In reality, you do not want to end up in acute care. The good part
Mhm.
about this for us is we can help prevent acute care. In one of the rules this year, and CMS proposed changing the STAR measures for hospitals so that if you do the poorest in the safety category, even if you're off the chart on every positive in every other category, you cannot be a five-star hospital. So they're
Mhm.
increasing the weighting of the safety bar. Day to day, medical errors happen. And
Yeah.
from a PT perspective, hospitals don't move people. Some do, but most of them keep people in bed. And then we wonder, we don't even call that a
Well,
safety
so
risk.
so that, right? Like it's that. Like as a PT, even watching, right? Like, and obviously I'm biased because I'm looking from my monoptic view that you need to get PT 3 times a day. You need to, um, there's no priority for movement. There's no priority for like it's like you're watching a hunk of meat idling in a chair, getting injections and getting vitals measured twice an hour, which is great. But there's more to life, right?
Or
There's
not
there's
so
more
great.
to it's really interesting, right? It's really interesting that we are where we are, and I'm so happy that the hospitals are being incentivized to maintain safety profile, right? So that they're getting a financial incentive to maintain a star system to maintain safety profile. But it's 2025, and we're discussing these overarching things, and yet some of the things that are simplest to fix, right? Atul Gawande had a book a couple of years ago called Checklist Manifesto, which his biggest claim to fame was he's a surgeon, right, and he's a medical ethicist, and he created a system in OR that had checklists to reduce error. Like it's simple, right? It's a simple until you check off all the dots, you don't move on to surgery. Maybe that's what's necessary for like an inpatient care provider. Maybe there needs to be a checklist that checks all the boxes so that you have a more optimal experience. Maybe you need an EMR system that actually nudges clinicians to communicate with each other instead of just logging in the intervention you've provided so that you can successfully bill the patient for the services rendered. So there's a lot of opportunity, I think, but this opportunity comes at the price of putting energy into the system so that we have a return on our investment, right?
It costs money to be safer.
Yeah.
The incentives in fee for service just don't create an environment where there's any incentive to be safer. But I will tell you where does high reliability organization come from, okay? Two types of organizations are inherently HROs or they cannot exist: nuclear power plants and airlines. Imagine if we didn't have a check and balance and a perfect or virtually perfect system where every single step was checked and double checked and there was no room for error. And if the slightest thing were to go wrong, someone raises their hand because people's lives are at risk. Yet we lose so many more, hundreds of thousands of people die a year in hospitals because of the simplest safety errors that if we had the same checks and balances in hospitals would not happen. And we accept this as a norm. Again, it is not sustainable. Just like anything else that is, you can see how once you shift the incentives, this pattern is going to change. This is what we're in the middle of now. We are in the middle of this transformation where the incentives are shifting and therefore the expectations of what comes from medical care are changing. And this is the kind of, as a theme, this is what we want to bring to people on this podcast is to share, look, this is happening. And this is exciting. Let's flex. Let's pivot our profession to be more aware of this and to be a part of how all this is
We
changing,
can do this.
right?
We can
We
do this. We have
can.
the capacity to do this. We can absolutely do this. But the question is, I think that the sea of change starts with a single individual. So it's again
That's right.
not to plug our Alabama company, right? But these individuals are taking change into their own hands. Like our friends in Alabama Physical Therapy Association are moving the needle. We can all move the needle on a small scale. You can move a needle in your clinic by taking ownership of these teams that you're building. Needle as an inpatient rehab provider by creating a structured, institutionalized, objective way to intervene with patients. Anyone has the ability to be the agent of change. So hopefully this is a call to action that even you, that physical therapist working in a high volume clinic who is 2 years post graduation, you can be the agent of change by taking ownership and equity in a type of triage you provide, by the type of clinical care you deliver, and by the type of camaraderie you assign with other clinicians to get them to also want to move the needle. So yeah, that's
No matter what setting. And we talk a lot about outpatient therapy, but here's an example from a hospital. You're a hospital therapist, right? And let's say you're in a hospital, one of the 25% that's going to be in the Transforming Episode Accountability Model in January. And remember, CMS has said that as long as it goes as planned, and they have many years of testing and other models to know that they have very strong confidence it's going to be successful. The plan is to expand the team model into more episodes so that any triggering event triggers the hospital's accountability for not just the stay, but 30 days after, okay? Let's say you're in a team hospital and the goal is to get the patient to have a positive hospital stay. Ideally, they maintain as much mobility as possible and are early mobilized. They're getting, hopefully, like hospital mobility and physical therapy. And the idea is to, if we can get them home, get them home. If you're a therapist and you're discussing the plan of care and you're discussing the mobility with the patient and the family, and you recognize they have the level of support that they need, the kind of care they might need the first couple of days they're home, but you hear the case manager talking about sending them to skilled nursing, while you understand that they can be successful with, let's say, home health and the support of family and maybe a little home health aid in the beginning, this is your top of scope in the inpatient setting to advocate for that patient going to the best setting for them, the safest setting, which whenever it is the safest setting should be home. Home with home health or home with outpatient therapy, home with reconnection to the providers in the community. But you get to be a patient's advocate for what's best for them by taking in knowledge, combining it with your expertise, and making that a recommendation as part of that care team. I mean, we have the ability to flex so much more agency than we do. Right? So
absolutely.
take that opportunity now to do those things.
Yeah. Like I love the Navy SEAL model. When you feel like you're being tapped out and you're depleted of energy, you're only at 70%. You still have 30% to go. It's that, right? Like the equivalence of running long distances is when you feel like you're really gassed and you're just out of it, you still have 30%. Like there is still a lot more. So yes, as a clinician, you're tired and you may feel burnt out and you may feel like there's nothing more left for you in the profession. But truth of the matter is there is. You can still be the agent of change. And if you need incentive, if you need motivation, find one point that can change under your directive and start working at it. Start working at it today. Like wake up and actually start seeing the world for what it is instead of only complaining. I think complaints are wonderful, but they're not actionable. Plays are the what, not the why and the how. The why and the how is what you get to when you start realizing that you can be the agent of change too. And so I just really hope that our profession as a whole, there's 270,000 of us in physical therapy. There's 270,000 opportunities. So 270,000 opportunities to be changing, to be the agents of change. So let's do it. Let's heading to PPS literally in 2 hours. I hope to see this on the field. And I think maybe we should meet in another couple of weeks to discuss that, right? But
Tell me before we go, what's one thing you're really excited or hopeful about from what you're going to get out of this PPS? And maybe share a little bit about what you're going to talk about, if you don't mind,
yeah,
because I think
so
you have a
so I
session.
think the one thing that I'm really excited about is I have seen the young clinician. So I have seen the young leadership taking over responsibility. So we spoke about that old guard and the young guard, and I'm seeing the young guard mobilize and move to start creating direction for our industry, and I'm excited about it. I am part of the old guard. I am aging out slowly but surely, right? But we need young clinicians to take equity and to take ownership. And I'm seeing that from the last couple of local conferences, statewide conferences. So I'm really excited. And I want to see that change in a direction at PPS. I want to see younger clinic owners showing up and asking for technology, asking for shift in the direction. I am speaking about a direct to employer option. So I actually have a panel and I want to discuss a way of offering services directly to employers and reducing musculoskeletal cost from direct contract negotiation with employers. So I have a couple of guests. I have a Scott Heber, who is a CEO and founder of Second Door. I have Aaron Cry, who is a founder and CEO of DPT, one of my former employers. And I have Bridge, who is a CEO of Spry, who is someone who's sponsoring me to be there. So this will be a good way for us to have a discussion. And we have Sam Shao, who is just a clinic owner in Chicago, who's really been wonderful about adapting to this change on a local level. So I want the panel to discuss the lessons learned over the last decade and how do we get this direct employer model finalized? How do we get this to the point where everyone has a playbook? Like, I need to know how to go directly to employers, and this is my playbook. This is how I get the payers aligned. This is how I get my clinicians aligned. This is how I negotiate a fee schedule for specific individuals. So that is what I'm speaking about. But yeah, I will report back when I return, and I think it will be a good topic of a conversation.
I can't wait to hear about it. And just to plug for our next episode, make sure you subscribe because you want to be notified. We have episode 21. We've been talking about our friends in Alabama, Jonathan Smith and Cody Lee, who are an outpatient therapy clinic through a health system in Alabama. And they're doing some really innovative work, taking a lot of what they have heard and learned from us and others about the opportunities for therapists to help advance value in healthcare, and working with their local ACO and with physicians that have become their partners, how they're educating those physicians and the reception that they're getting. So it's going to be a really good conversation. It's the first time we're having 4 of us on the screen. So many times we've had guests, one at a time. We're bringing the 4 of us to have this conversation. And again, it's a microcosm of change it's like a laboratory of the best kind. We're watching these young, smart phenoms in the therapy world who are flexing that expertise at just the right time in the right place where they found opportunity. And we cannot wait to have that discussion. That'll be coming up in episode 21. And thank you to everyone who's tuned in for any or all of these 20 episodes. We're learning and growing as we go on. Thank God for Alex and all of his research and the planning that he does. I don't thank him enough. I'm so lucky to do this with him.
Thank you, Dana. And I appreciate everything you do. Your knowledge and your expertise are
Please.
absolutely foundational. So every episode has been an exploration and an opportunity to learn from you. So I appreciate it.
Oh, ditto. All right, everybody. Thank you for tuning in to episode 20. Again, subscribe and like and share and all those good things. Take care.